again, my pleasure to introduce again my colleague and friend, Dr. Scarlet Soriano. Dr. Soriano is the executive director for Duke Integrative Medicine and Health, and she just recently assumed that position just I guess, just beginning in May, and we're really excited for her to be in such an important role. In addition, she is on the board of directors for the Academy of Integrative Health and Medicine, and I get to be with her as part of their Black, Indigenous, and People of Color Committee. She really has been a leader in thinking about systemic racism and inequities, especially in integrative health. She's also the co-chair of the Academic Consortium for Integrative Medicine and Health's 2023 Integrative Medicine Symposium. And again, I feel lucky to be working closely with her on that. She's the former director for group visits and wellness-based healthcare transformation at the Program for Integrative Medicine and Healthcare Disparities at the Boston Medical Center. So with that, I turn it over to you, Dr. Soriano.
Thank you so much, Darshan. What a treat to be able to share this time with you and with Peter and with everyone at the Osher Center and with all who are present here this morning. I hope that this is a peaceful morning for everyone who's taken the time to join. And I want to begin by calling forward and understanding that health and well-being are paramount to the survival of our planet, that integrative health and well-being modalities are foundational to the roadmap, the emergent roadmap forward. That I deeply believe that. And so every day I am moved by the ways in which a reconsidering, a dropping of boundaries, cognitive boundaries, perceptual boundaries, an embracing of a larger understanding of self, of other, of health, of well-being, to encompass a multidimensional self and a larger whole made of many, many parts is critical to an emergent vision of what's possible. So I'm going to unpack that. I've got some slides that, grand rounds without slides is, I guess, like going out undressed. We can't do that. But I'm calling you to engage with me in a conversation that goes deeper than studies and that goes deeper than the ways in which we have learned in academia to share our knowledge and to act upon that knowledge. I am going to call upon all of us to share stories. We are not in person. Hopefully in the future we'll be able to be in person, but I'm going to try and make this interactive within and interactive in among us. So please come forward, be present, and hold a few tenets. I'm going to try to make this as non-dry as I can. So let me go ahead and share my screen. And so, this title is it's as much a statement as a call to wisdom and a call to action. There is not one wellness strategy, but within us reside wellness strategies that are needed, voices that are needed, and in an energy and a momentum that is deeply needed at this time to rethink what health and well-being looks like. I think the COVID-19 pandemic has given us a profound opportunity to think deeply about how the biology and the psychology, in the spiritual experience, in the social experience, in the economic experience, the nested realities within and without must be attended to. And so, how do we write policy? How do we create care algorithms that no longer sidestep or acknowledge with a nod, but do not integrate, but rather fully embrace the multidimensional reality that comes together to create well-being or disease? So I have no disclosures. And these are some general objectives. We'll see. Hopefully there will be more that happens, but we want to talk a little bit about the multifactorial nature of the inputs that affect personal and community health outcomes. And we want to, and we began already in that mini intro, to think about fundamental concepts, right? What underpins our understanding and also our emergent understanding, our current understanding and our emergent understanding of health and well-being. And then I want to just offer some thoughts, some examples, some of what's happening in my institution. It's just very, very early on. And then some world examples that stand as landmarks, at least one of them. So please, I can't see all of you, it's too bad, but wherever you are, take a moment. I'm just going to invite you, close your eyes and ask yourself, to me, as a living being, what is health? And just allow that to emerge in as full, as rounded, and as lived an experience as possible. And I'm actually going to invite you to take this a step further. And I want you to think, I want us to think, to call forward of a time when we felt particularly well, when you felt your most vibrant, your most alive, your most harmonious, really well. What was happening? See if you can call forward a memory where every dimension of well-being was just right. Where were you? What were you doing? Who was with you or not? What were the surroundings for that moment that you found yourself in? And you can, if you had your eyes closed, you can open them, or you can look up or attend back to this. Engage the left hemisphere again. And then seeing that we have a chat feature, I think that this is enabled. If the chat feature works, I would love for you to just, if you feel comfortable, write in. What answers came forward for you? What is health for you? And when did you feel most well? I teach, have taught for the last 3 years, 4 years almost, a physician wellness class at Boston University School of Medicine. And I often begin this way, just with that visualization. And it is incredible as we launch into wellness for physicians and addressing the challenges that our reality currently holds, how their visualizations 100% of the time have nothing to do with the day-to-day experience of medicine as they're experiencing it in their 3rd year. It has to do with that hike they took with the starry sky, with that perfect wave, or with that incredible party, or with that grandmother's song that still they recall and brings them to tears. So I don't know if the chat is enabled. If not, then please write this out for yourself or just hold it in your heart. But think about how often it is in the non-clinical, it is in the when nobody's watching, or when my sister extends her hand and puts it on my shoulder, or when that perfect sunset happens, that well-being is felt, recorded, and becomes easily available when the question is asked, when did you last feel well? When did you feel so well? So what's meaningful to us? And so why do we not, or can we design healthcare structures that start there? So one of the questions that I offer us as we engage today is, what would it look like if we designed healthcare interventions that began from that premise, from the premise that health is created outside our current clinical spaces for the most part? They have an important role, especially in addressing acute emergent situations. What would the clinic look like? What would the clinic community interaction look like? So I'll give you my definition of health as I've had sort of my own journey in throughout, and in my work with people and communities. I've come to experience that a sustained, innate, coming from within experience of mental, emotional, spiritual, social, which includes a lot, within that cultural, socioeconomic, racial, etc., well-being that manifests as optimal function and the highest expression of what I believe to be my purpose, which also contributes in the same way through that through that harmonious experience within me to greater harmony in the larger collective. It's almost like a fractal, right? Like an expression or a note that builds into a larger song, a larger melody. Let's see if I can. So where's the gap, right? What happens between what so many of us, when we're asked to account for what makes us well, how does that become so different from what we experience in our role for those of us that are clinicians, or what we experience oftentimes within clinical structures as patients? And Dr. Terry Mason, who's a well-known neurologist, he's got a radio show called, I believe it's called The Doctor in the House, an AM radio show. Recently in an interview I was listening to, said something that was very powerful about his own transformation and how he talked about being a steak a day guy for a long time and having to make some major changes to his diet and to his mindset, and what's happened to his offering to the world as a result of it. And we'll see one study that he and Dr. Kim Williams, former president of the American College of Cardiology, were part of. But he put it in a way that I could understand. Shifting paradigms from what we experience day to day in so many of our environments to what I began us dipping our toes into, that felt experience, that nuanced experience as a human being. Making that shift requires us, as he says, to move to the side in our minds, in our spirits, the things that we've been taught to believe, because the way that we've created our system doesn't facilitate it. So then how do we bridge that gap? And so I like I like to be a non-linear lecturer. I like to be a storyteller. I like to engage in ways that are ancient and that are known to us and that are called forward. And I also like to give you kind of the end at the beginning. If you fall asleep in this talk and you take nothing, you're like, oh, that lady, what was she talking about? Keep this word, harmony. My patients and students always laugh when I joke this way. I say, okay, here's the one word that if you hear nothing else, harmony. Another way to think about it that emerges more so in our literature is coherence. When we're thinking about, for example, heart rate variability or the functioning of bodily systems. But to me, harmony, which is so much more universal and understood, I have found in my experience, and I'm very interested to hear yours as we talk about in the Q&A, that aiming for harmony, inner harmony that leads to outer harmony, has shifted me so that I am much more enthused and capable of bridging that gap, the gap between our current reality and our aspirational state, which is also a felt state of well-being outside the clinical space. And I also have learned in my short and humble walk that just as cultural humility is absolutely essential for growth and for awareness and an expansion of self to include the seeming other, humility when it comes to healing systems, so systems of knowledge, is essential. And I'm choosing one in the interest of time, but really this is a reminder that there is tremendous wisdom that has resided, just as that in that experience at the beginning of what makes me well. There's a tremendous amount of knowing that comes in. There exist bodies of knowledge within us, among us, thousands of years old, many of them, some not, and equally robust, but deep, ancient wells of wisdom that have passed us, or we have passed by in our 300+ year old, amazing, robust, incredible, needed system of understanding. And so I am calling forward a humility of perspective and a willingness to look beyond the conceptual boundaries that have delineated right and wrong, good and bad, health, not health, appropriate, not appropriate in terms of treatment. And I do so through the lens of Ayurveda. Ayurveda is considered perhaps the oldest whole system of medicine, emerged in India and emerged deeply woven with meditative, contemplative practices, with the oldest Ayurvedic text, the Charaka Samhita, which I'll quote in a second, being about 700 BC. This is from the actually the Sutra Samhita. The definition, as I understand it, and I am not an Ayurvedic practitioner. I've had an interest in done some learning, but nothing no qualifications to speak of at all. But the definition of health, I gave you mine. Let me give you Ayurveda's definition of health, which is in Sanskrit and translates roughly to one who is established in the self, who has balanced constitutional energies from that particular sort of epistemology, this idea of an energetic constituency, a balanced fire of digestion, right? Balanced, which has emerged in integrative health, as you know, as a very important, gut health as being essential to overall body health. Properly formed tissues, proper elimination of waste. All of these things, you can kind of see how 5,000 years later, there's an important correlation, well-functioning bodily processes. But then this last part is really important, and whose mind, soul, and senses are full of bliss. only that person is called a healthy person. And so in doing this, my intention is to gently push our comfort zones around multiple dimensions. What is health? Where do I draw my definitions of health from? Is it from the evidence as I know it from what I have learned, or is it from the evidence that expands beyond what I have learned from the 300 plus years of knowledge that have informed my institutions of higher learning? Do we weave all three? And how does that lead to the creation of different structures that ultimately, most importantly, lead to different outcomes? And how do I dance in that place of discomfort? Oftentimes, when we press against a conceptual boundary, it is uncomfortable. It is uncomfortable when something doesn't fit what has become an unexpected way of understanding. And yet, can we, as a person, as a clinician, as a policymaker, as a teacher, as a being, be in that space and push past the discomfort towards a generous curiosity, or as is used in anthropology sometimes, a hermeneutics of generosity? I'm going to just offer one last piece from Ayurveda before we fast forward 5,000 years. And that is that there are a couple of there are many beautiful concepts in that body of knowledge, but there's this concept of prakriti or prakruti. I've seen it written both ways, and same with vikruti. In vikruti. In prakriti or prakruti refers to that kind of set of conditions with which a person is born. And within their text there's a mention of maternal factors, such as maternal lifestyle choices and uterine effects, etc. And then vikruti is the current state, which often is a state of imbalance. And it's a state of imbalance oftentimes caused by that interaction between what we came in with and what we are experiencing in our environment. And so it makes me pause, because when I look through the lens of integrative health or health and well-being and just wonderful, good, caring medicine, it's easy to see how there is a sameness in the difference in these bodies of knowledge. We know that epigenetics, that lifestyle choices in the mother affect the offspring in many cases, right? We know that our genetic code, with a few exceptions, by and large, is really an interactive, dynamic set of information that is pushed in one direction or another, based in how the cells are bathed. What's the biochemistry that's bathing them? And that biochemistry is affected by the choices that a person's making. And those choices are affected by the realities in which that person exists and by their perception of a locus of control or an ability to effect change in those realities. So these nested realities are very much alive and come through in our science. We aren't just byproducts of a machine. We are relational dynamics that can be moved and shifted. And we have profound ability to change that. So again, keeping that policy hat, keeping that practitioner hat, and keeping that comfort in discomfort of conceptual change. Let's kind of hone in a little bit, and there's so much data out there. I'm putting in a few studies really just to bring the illustration home and remind us of some of this information. So I make no claims to the fullness of these bodies, but we know that diet, that nutrition really matters. We know that what we eat is going to have a dynamic conversation with our immune system. It's going to have a dynamic conversation with our microbiome, which in turn is going to impact our immune system. That the kinds of short chain fatty acids that's illustrated by this one population study shows that, as illustrated by this population study, that the kind of short chain fatty acids that I make are going to be different based on the diet that I'm eating, in that, like, for example, butyrate, some of those cross the blood-brain barrier and are going to impact the level of well-being, inflammation, non-inflammation, glial activation, non-glial activation in my brain, and therefore my neuropsychoimmunologic profile, right? That in my, as I wake up in the morning, that feeling of, oh my God, it's raining. I'm so glad the flowers have water, or, oh, I can't take another rainy day. Like, I can't do this, right? That subjective experience is influenceable by the choices, the diet choices that I make, quote unquote, which are themselves deeply influenced by my positioning in society. And so it becomes almost impossible not to begin to tear down, as Terry Mason said, those conceptual walls that gave birth to us potentially as clinicians or practitioners in the Western world, and beginning to say, wait a second, we need more dimensions here if we're actually going to stem any tide or address what is really happening for a person. And I know that I'm speaking to many who are masters and who know this much more deeply than I do. And so just accept my humbleness in my presentation here. We know that not only nutrition, but also adverse childhood experiences. We know the ACEs studies. We know that stress in general profoundly impacts that conversation between prakriti and vikruti, right? Between what we came in with and how we are manifesting our potential. We know that that some of these lived experiences that may be related to a history, for example, of deep institutionalized racial injustice or gender injustice or other forms of differential evaluation of life, that they actually affect biology. And so they have to come into the clinical space, but also beyond the clinical space, into the foundational concept of health. If nothing else, what is in that word harmony, right? For those that are about to fall asleep, if we open that word harmony, what we're doing is we're looking at what comes in to create harmony or disharmony. And so this is actually one study that thinking about the prakriti vikriti or prakriti vikruti interaction, right? Our engagement with our environment. A recent study, small study that I mentioned before, with multiple people, including Kim Williams, the first African-American vegan president of the American College of Cardiology, Dr. Terry Mason, and others, as you can see here. And they took a population of African-American people in an inner city space in Chicago, I believe. And they were given 5 weeks of home delivered, low sodium, low calorie, no cholesterol, non-dairy, so vegan diet. And they were looking to see what happened to their cardiovascular risk. And you can see that their 10-year ASCVD risk reduction was almost 20%, with a very significant, with very statistically significant. And one of their conclusions in their study, from this very small study, there's a lot that we can discuss about, you know, plus and minuses here, and the fact that this is very controlled, these meals were delivered, but if we think about these big racial gaps, right? And we see these discrepancies, not just in terms of race, as we'll see in another study, but in terms of class. And we see the reality of food deserts, and we see what segments of our population are eating. And we see how a simple intervention, reliable access to mostly plants, brought into the body within a short, extremely short period of time, shifted biochemistry profoundly. As a policymaker looking at cardiovascular disease as the #1 cause of death, as a community member, as a family member, as an individual, this is of incredible relevance to me. And the blurring of the lines becomes really essential in order for me to be able to behold the potential for true interventions. Another recent study looked at data, the data collection. The study was recently published, but they were looking at older data from the Midlife in the US study. And they had a somewhat skewed sample, and they acknowledged this, and this may be part of why their findings were as they were. As you can see, 226 African Americans, 978 white Americans. The African Americans more clustered, but they combined multiple discrimination scales to create a pervasive discrimination scale, basically a pervasive disparity scale. And then they also looked at markers of allostatic load, and they were trying to map whether pervasive discrimination, how pervasive discrimination was manifested in the body based on this, again, one little snapshot, lots to say about quality of evidence, but important information in terms of thinking about lived experience. And they found that a pervasive discrimination score, which I have in the slide prior, they took the kind of top tertiles of these 3 different scales and created a pervasive discrimination score. And if you were in the top tertile, you got a 2. If you were in the lower, in the mid, you had a 1. If you didn't, you had a 0. And so they looked to see how people's self-reported experience of discrimination correlated with data that had been gathered that was associated with allostatic load, and allostatic load being, we understand it as an excessive burden, as an excessive load on the physiology, usually thinking in terms of cellular health. And they were looking at a number of different things, like waist to hip ratio and I believe body mass index, but I can't remember if that was one of the ones in this particular study. They were looking at blood pressure. They were looking at other sort of outcomes of basically what we now know as chronic inflammation. And they found this significant correlation. They interestingly did not find that race in this particular study correlated in the same way, sort of uniquely, when other confounders were subtracted with allostatic load. Their thought was that their sample, they had a very kind of skewed sample of African Americans. They didn't have, they had a also large majority of the study participants were white. They might not have had the power to be able to discern in this particular study. However, they did say that effect sizes on all these measures were significantly larger for African Americans, which was the minority population they were studying in this particular study. There are of course many others that could be similarly studied. But again, this relationship between our environment, our sense of well-being, and what manifests as health and disease, and how do we emerge with different concepts and different models. this is an older study looking at 3 areas of Detroit, and looking in this case at socioeconomic status. They were looking at a number of populations, there's 3 different areas, and they found that neighborhood poverty, so their hypothesis was, aside from individual risk factors and individual kind of characteristics, how does the health of the neighborhood affect allostatic load? And in this case, they were also looking at measures about like things like CRP, waist to hip ratio, et cetera, blood pressure, cholesterol levels. And they found a positive association with higher allostatic load, independent of individual household poverty, as well as other confounders. So what the neighborhood feels like, looks like, how invested are we in this neighborhood has a profound effect. And we know these things, right? But sometimes we don't move until we see it reflected back to us. Just one more point as we're kind of creating a picture of realities that interweave. Social connection. We know this is a major issue for all of us. We know the pandemic has really brought this home significantly. And we know that our elders in particular are a very vulnerable population. And so this, again, an older study with a very large population, looking at 2 kind of similar but different aspects of affecting the potential health effects of social connection. They were looking at loneliness, and they were looking at social isolation. And the idea was to try and differentiate loneliness as a subjective feeling that whatever level of social connection we have is not enough, right? So loneliness teased out as a self-report of not having the level of connection, of social, familial connection, of engagement with others that we think is important for our health. And that was associated with higher odds of reporting mental health disorders. Separately, actually, isolation was also associated. They both were, and certainly isolation was associated with reporting poor health. They had just a binary system for self-report of health. So it was either good, very good, excellent was one choice, and fair, poor health was the other choice. And so the lump that included the poor health was more likely to be reported for those that experience lower social connection, in particular isolation. And so, we've meandered, right? We've gone in, we've gone out, we've looked at data, we've looked within ourselves. So I invite us to think about, well, how do we move forward, right? How do we call upon our personal and our collective creativity to emerge with different models, to go into the liminal space, to sit in the discomfort of falling paradigms, of ways of being, and actually go through that experience, which I'm doing no justice to, because that's a profound experience of expanding fundamental understanding of how the world works and who we are vis-a-vis others. But if we go there, what is it that's calling forward to come, to emerge? What is it that is nascent? And I'll tell you a little bit about what has been nascent for me. And I really would love to hear about what is nascent for you. And I'll tell you a little bit about kind of where we're being pointed. If I were to, this is another, if you fall asleep, this is it. If I were to encapsulate my learnings in what I get up in the morning for, is inner transformation as a vehicle for outer transformation. That the focus now be not just on making sure that I meet all my metrics, or that everybody gets their foot check and that's a diabetic, or that, but that we embark in a journey that supports the being to become both self-empowered and hopeful. That what I I call it empowered hope, right? And that empowered hope arises through a variety of mechanisms that have a strong inner grounding, a shift in self concept, an embracing of meaning, and a sense of purpose that then lead to different choices when nobody's watching, into a much more empowered engagement with unjust systems and with disparities. That my hope, if I were to put it into just a few words, is that we experience inner transformation that leads to change makers in the system at large for the social good. And health becomes a downstream effect, a very quick downstream effect from that. I want to pause here, and I'm going to move quickly because we're running out of time, and really speak to trauma. So much of what ends up emerging as physical dis-ease, disharmony, is related to experiences of trauma. We saw, some of this captured in pervasive discrimination, right? That's trauma. In adverse childhood experiences, that's trauma. In inability to eat the food that your body needs, even if you want to, that's trauma. And so I want to pause and name trauma, because as we're building policy, as we're writing and creating, we want to think about, well, what encapsulates some of these things that are the manifestations of disharmony in our society. And so what's emergent in my experience, so now moving towards solutions, is supporting the profound transformational power that exists within us. So honoring and kind of harnessing neuroplasticity, the ability to change and emerge, and tools that allow that, to engage, to activate the human being to become an agent of change. And that requires success, right? That requires not just that we talk about the fact that I'm worthy and I'm important, I have something to contribute to society, but that I gain skills that will help me to be able to successfully navigate traumatic or stressful experiences, and that will continue to build an emergent sense of self, or a transforming sense of self that feels capable of actually shifting tides and providing solutions. We are not blanks. And I think that's so important. And the folks that we remember in history, remember that, became activated. And all of them are in us, right? The child that could join a gang could also be the next Nelson Mandela, or the next whatever it might be. And so here are some of the things that I have found now on a very practical level. I have found that quieting the mind, that mindfulness, meditation, breath work, whatever contemplative practices allow for the experience of metacognition and discernment, have been extremely helpful in my experience working with people, in particular in my experience working with groups and wellness-based groups, for supporting that self-agency and that sense of empowerment and ability to self-modulate. That is what we want, because the decisions are made when nobody's watching. And so we know that mindfulness practices support this sort of noticing and self-correction. And in mindfulness, I use very largely. I'm going to zoom through this, but I wanted to give you a practical application. A QI project we did at Boston Medical Center with Dr. Rob Saper, who is our lead, and Gabriel Farquhar, who is our amazing program coordinator. And we looked at burnout among clinicians. We had folks from all of these departments, And we measured burnout. We put them through, it's a terrible language to use. We had crafted experiences that were highly contextualized, drawing from cases that were relatable, so that this doesn't become, a monk in the Himalayas, but deeply contextually rich. We fed them, we shifted some things, but we saw in an 8-week process, and many of you have seen that similar data, but it's profound to be in it. We cut burnout scores in half, right? And these physicians and nurse practitioners that participated in this particular cohort, that was a clinical cohort, we then went on to leadership in the hospital and to other groups, had deep transformational experiences. We also did that we had an amazing group with our transport employees in our janitorial staff, right? So really thinking about, how does an institution make change? And we know that we need to harness that metacognition. Let me sort of re-say that. We know that harnessing that metacognition and harnessing that ability to feel empowered is accompanied by substantial brain changes. This is a meta-analysis that just shows greater coherence in the brain after mindfulness-based stress reduction, using this as a stand-in for something that is much vaster. And I just want to say for a moment here that the roots are very rich and ancient and not captured here. We see that the prefrontal cortex comes online. We see that the ability to perspective take, to not be driven by the fight or flight response, becomes activated when people learn this practical skill. We also know that kind of off the mat, meaning the meditation mat or cushion, there are studies. This is a tiny study out of China that looked at what happens for people that go through a compassion-based meditation training and then are put in stressful situations in a non-meditative state. And they found similar, when looking at their functional MRIs during these exposures to stressful stimuli while not meditating, that just having had that prior meditative experience significantly reduced amygdala outputs. And you can see this, you saw the same in the prior meta-analysis around amygdala outputs and sort of insular activation with meditators. And so we want that, because we want at 3 a.m, right? At 2 p.m, when somebody is cutting you on the road, that's when these skills need to be available. And I saw profound examples of that in my work at Boston Medical. I'm not going to have time to go into polyvagal theory, but that's an emergent theory that is giving us some really wonderful ways to think about how do we activate the part of the vagus nerve that is most engaged with prosocial behavior and with downregulation of sympathetic tone and associated with social engagement. We know from studies in heart rate variability and from sort of the work of the Heart Math Institute, which has done really wonderful work looking at heart-centered emotions, how, for example, if you look at the graph here, how heart rate variability shifts when you hold a positive emotion, how there is a mirroring within bodily systems of the coherence of a higher expression of our emotional state. And, this sort of beautiful sinus-like wave is what's considered to be a more coherent heart rate variability, sort of overall variability wave. And you see that in this particular setting in something like appreciation, different, although you have more coherence with other things like relaxation, and a lot less coherence with things like anger. They've done other studies looking at immunologic markers like salivary IgA and downregulation with the negative states and upregulation with the positive states. So we know that there's a conversation happening. One of the tools that I used tremendously in my work on groups at Boston Medical Center was the heart lock-in breath, which is from the Institute of Heart Math. And it involves breathing into the heart. So calling the mind back into the heart and then bringing forward a positive memory like we did at the beginning. And then as you breathe that out, breathing it out to the world. And this simple breath that was a very important sort of part of our toolkit at Boston Medical was actually profound in altering people's experiences of well-being and has been shown to significantly impact heart rate variability, which we know is a prognostic, it's prognostically associated with risk of heart disease. So, and then just one word on nature, because this is what reality, where if we're talking about nested realities, and we know from our experience of the pandemic that the health of the planet is absolutely essential to our own health. And we know it, but again, just a nod that there is plenty of emergent data showing us that what we know is good, that what we know and what makes us feel good actually is probably good to think about in terms of building policies for wellness and for health and healing. And then hope, back to hope and pain, a tiny, very tiny study looking at hope and pain and seeing significant increase in self-reported well-being in group counseling that was focused on hope. So as we move towards designing interventions that are going to better address the ocean of suffering that we are experiencing right now, how about we look to nature? How about we look to harmony? How about we look to inner transformation that leads to outer transformation for the self and the larger whole? How about we look at relatedness, and how about we look at multidimensional realities within one being as absolutely sine qua non for any successful program? So what are the ingredients in our little soup? A strengths-based approach to engaging the self and others, self-compassion. These are some of the things that I've built around relinquishing of judgment, gratitude. I'll give you an example of some of the things that I use in some of my, in the curricula, in the groups. We talk about how our narratives, how they make us feel. What are the tools that we can use to change our negative self-talk? What are some of the things that a loving kindness attitude can do for ourselves? Here's one patient story. I unfortunately will not have time, but this one person in our groups weaned off all opioids, even though we never talked about opioids in our group, because mindfulness meditation and thought, her own ability to modulate her thoughts was so powerful in changing her pain levels, and was able to subsequently return to work. What are the costs? What are the gains? What are the reduced costs to the system for those that need those metrics? What are the gains in terms of well-being? In our groups, we talk a lot about interconnection and relatedness, and our caring for ourselves necessitating our caring for each other, reclaiming community. And we mirror that and reflect that in terms of caring for each other. We talk about nourishing in food as well as thoughts and emotions that nourish ourselves. One of the cases that I have is this gentleman, Morris. I'll suffice it to say that at the end of my first presentation, and name has been changed, he looked at me and he was like, "You must be crazy. What are you talking about, all of these vegetables and all of these things?" And we took a culturally contextualized, relatable, fun, in the teaching kitchen, in the group, make the food, taste the food approach. And at the end of a 6-week group visit, he had actually, similar to the woman who stopped her opioids, we didn't talk about alcohol, on his own had stopped alcohol, had stopped soda and junk food. He came in the last day or the second to last time, and he touched his toes in front of the whole group. It was like, look, I can touch my toes. 6 months later, he was still doing well. He'd become a teacher. He became ignited. That to me is what I want to build around. This is unpublished, very tiny QI data from one of our studies using the Promise 10. And in one of our chronic pain groups, using these concepts that I discussed, we saw a significant change in physical health. You see the baseline and you see the trend moving up. These aren't statistically significant. We saw a shift in mental health. We saw the curve move towards better health. We saw the averages for the group crossing boundaries in terms from poor to fair physical health and from fair to good mental health. And we saw people speak and embody a change sense of self, and a change sense of self when nobody was watching, which is the key. So the last, if you don't hear nothing else, here it is. That to me is the secret ingredient. That's it. And I'm not the only one who says it. I'm going to give you in 30 seconds an example that has helped be a roadmap to me. She's known as Amma Matampritananda Mayi Devi, an incredible humanitarian. Her organization, Embracing the World, has been given consultative status to the United Nations because she's more effective than whole countries at mobilizing people. And her approach, and she was given the Gandhi King Award, that the two prior recipients before her were Kofi Annan and Nelson Mandela. So that order of magnitude of impact in the world. What are they doing? They are building on love. She says that we are all beads strung on the same thread of love. And that means
Scarlet.
Oh, we have 1 minute.
I'm so sorry. I just want, yeah. So I want to leave that as the quote. If you want to leave that quote up, because I think that's a beautiful way to just, because we're just right at time, and I want to just respect everyone's time here. If you want to leave that other quote of Amma's up, just as a final thought.
I will do that.
I know people have so many questions, and we're so grateful for you to be here and share with your just your vision and thoughts. And I know people have questions, but we unfortunately won't have time to.
I will make myself available to folks. You can email me. I will tell you that there is quite a bit coming up at Duke Health and Wellbeing. So stay tuned for the programs that are coming out of Duke. Yeah. And please, if you can share my email, folks can reach out.
Absolutely. Well, if you email us at the Osher Center, we'll happy to forward the questions along your way, Scarlett. And again, thank you so much here to giving us this wonderful presentation and sharing your wisdom. And I just want to remind the audience that we will have our next grand rounds here on Tuesday, September 6th with Dr. Gurjeet Birdi, Stretching the Breath. And then we'll also have our Integrative Medicine Network Forum, the lived experience of depression, an integrative perspective and approach. And so that will be on November 10th and 11th. So please join us. Again, thank you to everyone for coming. Scarlett, thank you so much for giving us this presentation, and we will see you next time.